And we have two programs that we're talking about today. And I will go ahead and turn it over to Julia Mecklenburg for introductions. Thank you, Julia.
Thanks, Joe. So we're really excited to hear both from Project HairCare and from the Aurora Mobile Response Team. From Project HairCare, we have Dr. Alex Reed, who is an associate professor, director of behavioral health education, University of Colorado Family Medicine residency. We also have Dr. Terri Richardson. She is the vice chair of the Colorado Black Health Collaborative. And then with Aurora Mobile Response Team, we have Courtney Tassin, who's an LPC. She's the Crisis Intervention Program Manager, Housing and Community Services at City of Aurora. So thanks all for being here, and we can get started with Project HairCare.
I'm Terri Richardson, and I'm a retired internist and also the vice chair at the Colorado Black Health Collaborative. And thank you for inviting Alex and I to be here today. We'll try to give you a little bit of flavor of what we're doing with Project HairCare and how it came about. So next slide. So I'm going to start out by telling you a little bit about our base barbershop salon health outreach program, because that allowed us to really hit the ground running. So in 2000, a little bit before 2012, Dr. Connor, one of our volunteers at CDHC, planted the seed to start this type of program. He had attended a conference and heard a lot about checking blood pressures in the barbershop. So he thought, why can't we do this here in Colorado? There had been somewhat of a program here, but it was grant-based and it was kind of on its way out as we started our program. We started in February of 2012. Because we really felt there was a need. There are high rates of high blood pressure and cardiovascular disease among Black people in Colorado. And the shops are just sacred spaces, natural places to meet people where they are. So we started with one shop, the shop where Dr. Connor had gotten his hair cut since high school. And then we've built up to 14 shops. Our shops are up and down Colfax, from York all the way down to about Syracuse. They're in Northeast Denver, and then other spots in Aurora besides the Colfax part of Aurora. And we do basic screening, blood pressure primarily, education. We educate people in the shops even if they don't get their blood pressure checked, and then refer. So we have this relationship and partnership that allowed us to have visibility in the space. And that sets the tone for how Alex was able to reach out to us and get the Project HairCare going. So next slide, please. So because we have this relationship with our shops already, we were able to identify 3 champions that will help us really shape and form this project into what it is today. We had Roz, Tracy, and Michael there at the top. And the 2 women are salon owners, and Michael's a barbershop owner. And then we have our project team, our coordinator, Alfreda Connor, who's a registered nurse and actually Dr. Connor's wife. Myself there is kind of a part of the team lead, Alex team lead, as well as a therapist, Dr. Alex, and Dr. Ivy, who do some of the programming and deliver the sessions for the project. Next. And so Project HairCare came, you'll see our logo there, because it's really about giving care, meeting people where they are. And it's not just about the hair, but the hair is part of it. And so we really want to change the stories around mental health in the shops. I see someone says they love the logo. We did too, but an interesting point I brought up is when we were putting this together, we, of course, have the traditional caduceus with the serpent's head, but one of our champions is a minister and thought, oh, we can't have serpents. So we just made them balls, so it is similar to the medical symbol. And of course, the scissors and the hair below, it's hair, but it's also the roots. So that was really symbolic in our quest to change the stories around mental health in the shops. On to the next slide. So our goals were initially to invite up to 28 Black operators, that's stylists and barbers in Denver County, to participate in the monthly educational experience around mental health, mental wellness. And we chose Denver County because our grant at the time had that stipulation, it had to be Denver County. Our operators, we were wanting them to learn about common mental health conditions that they would see in the shops and salons, and provide them some tools that they could use themselves, but more importantly, they could use with their clients. And also, we've been vetting resources in the community around mental health that they could recommend to their clients and also utilize themselves. We also have developed a microsite with some resources, with information about the program, and also about these shops. We want to give them some notoriety as far as what they were doing, and also developing a support network. And we were able to accomplish all these things, and we'll tell you a little bit more about that on to the next slide. And here we have the University of Colorado Family Medicine Clinic, and it's in a great location. It's on Quebec and MLK, so really still quite in the community. And this is where our educational sessions were held. And this was, as I said, a great location. We have the shop owners up and down Colfax in Northeast Denver. So this was a kind of a sort of a central location. On to the next slide. And we're fortunate to be able to have that. Just wanted to tell you all a little bit about the operators there, because there's a lot of diversity. They were all African-American women and men, but they represented barbershops and salons. Some were combination shops. We had female barbers and male stylists. Sometimes in America, we get locked into gender roles and who should do what, but it was great to see female barbers and male stylists. We had diverse age group. Some were younger, some were a little bit more seasoned. They had various experiences with mental health challenges. Some of them had really unique personal and family experience with mental health challenges. Some didn't have as much, but all of them were very engaged in the community. And they really were culturally African-American. And we don't have time to go into the detail about that, but we thought it was important to give you a view of the people and not just a program. These are the people that we're hoping to impact with this program. And you'll find later that we do believe that we've had an impact already, although our program is less than a year old. This portion of our barbershop salon program is only about less than a year old. On to the next slide. This might be Alex. No, this is the last one I'm going to do, but I love having this slide in here because these were the most common mental health conditions reported by those 3 champions that I introduced you to at the beginning. And they talked about some of the traditional mental health challenges like anxiety, depression, suicide, people being medicated on various drugs, death, grief, but also racism and microaggressions and internalized racism, the things that you deal with here in America, the superwoman syndrome, Black women having to feel like they have to do everything, bring home the bacon, frying up in the pan, all that stuff. And then some of the less traditional things that we think about around mental health, money, financial issues, pimping, pandering, and prostitution. That's one of the ones that they named. So from this, we were able to develop our list that our therapists went on to develop sessions for and informational materials. So I'll pass it over to Alex and he'll tell you a little bit more about the sessions that we've been having. But it's connected to working with our champions and getting their input on what they're seeing in the shops.
Thanks so much, Terri. And, to build on that point of Terri's, I mean, one of the things that, as we were learning from our champions, what they see in their shops and salons, these are the issues that I see in my own clinic, with the patients that I'm serving. And I think, similarly for you, Terri, as a physician, a lot of these are the things that you see as well. And, I think that really highlights that, the operators are hearing everything, everything that we're hearing in clinics, and why they're also just such an important, resource within the community. And I have to say as well, I feel so lucky to get to work with Terri on this. one thing we didn't really talk about, but I think is important to highlight is we've worked for some time together, just building our relationship, and collaborating on this program, which has just been a true joy. So, so continuing, we with the educational sessions and the really educational materials that we wanted to focus on, we took what we learned from our champions and created this list of topics, and they were very much in agreement with what to review. Though we also wanted to start from a place of mental wellness and not just focusing on what is wrong, but also what is right. And what is mental wellness as well, and not just and recognizing that this is also on a spectrum as well, and from well-being to the challenges that can arise. So the first thing we did is as we started this, we wanted to just gather some information from our operators about their own, their really some of the demographics. How long have they been doing this, and what have they been doing as well? And so as you look here at our survey results, and we're going to be following this up at the end of our training as well. So we've had up to 22 total participants, and that's varied just depending on, the session. These are very, very busy people, and often they're working 6 days a week, sometimes 6.5. And Monday is typically the day that they take off or may have a reduced schedule. And so they're really busy. And we were grateful that they were able to, attend these sessions as well. And you can see we had a range of folks who had a variety of different roles. You can also see here, it's really remarkable how long they've been doing this work. The mean age that we had was 20, or mean number of years as an operator is 24.36, with the range going from about 6 to up to like 48. So it is incredible, and really speaks to how all these operators are an important part of their community as well, and a huge resource. So one of the questions we were really interested in was just, finding out, what do they talk to their clients about when they hear, maybe hear mental health conditions or something that reminds them of that. And you can see here that, they're talking about everything. In particular, though, really talking quite a bit about alcohol and drugs, and also grief and loss as well. But mental wellness, even PTSD, so quite a bit as well. So they're talking a lot about these topics. As we continue, when we asked what did they give advice about, it continues with that trend of alcohol and drugs, and then also grief and loss, but also what mental wellness, depression, suicide, and PTSD. And you can see how the numbers change for that as well, depending on the topic. We were also wondering, when do they refer folks and their clients out as well? And so you can see here as well that they refer for everything, with a focus more on mental wellness and depression, suicide, and grief and loss. And this also is interesting in thinking about the timing of some of this, because as we were getting this information, this is post-COVID, and yet people continue to recover from that and are struggling as well. And we were also curious to find out, what do they feel most confident and the least confident in talking with their clients. And they feel really confident talking about grief and alcohol, and then less so on depression, suicide, and PTSD as well. And this one was really, really interesting to us in terms of, we really wanted to know, do you feel like this is a part of your job? And, and what we found is that they really do believe that this is a big part of their job, or at least one of many duties that they do, and that they do in fact have the time, despite how busy they are. They have people just churning through their shops, and they are very busy. That they some have skills, and they have some knowledge as well. And they also, though, are not shy about, trying to help their clients, because, one of the things we've talked about so much and is that what they provide is a sacred space in the community, and one that their clients feel more comfortable talking with them about what's going on than a psychologist or their doctor or PCP. So the goal of our program is to have 8 sessions going over the topics that we reviewed earlier. And so this is kind of what our sessions typically look like. The first is we meet at the Family Medicine, the AF Williams Clinic, and there we do serve quite a few folks throughout the community. And we have a conference room there. We provide food for them to make it a welcoming space. And that way we can also break bread together. And then we chitty chat for a bit and then check in and then get really into the topics at hand. And so from this, we really try to elicit from all the operators, like, what do they think about these topics, or what are their perspectives? So, we ask them and talk with them about, what do they think mental health is as well, and getting their perspectives on, what that can mean. We also work to provide tools for them as well, with the idea being is that as they are hearing these stories, they have their own experiences and tools. We just wanted to add to their toolbox, just like our operators don't just use one comb and one set of scissors. They use a lot of different tools based upon, the hair that they're working with. And so we asked them, we started off, our first topic was on mental wellness and, what do they do for their own mental well-being? And so that was really fun to hear some of that. Then we also will give tools as well. And so some of the specific tools, like these examples, are we talked with the operators about using the dive reflex. And the dive reflex is just, in another way, it's really just when you splash cold water on your face. When you do that, you're setting off your relaxation response in your body. And that can quickly lower your heart rate and help people to feel relaxed. So what we did was we filled up Ziploc bags full of really cold water, and then we had them try this out. And one of them even had a Apple Watch, and they were able to watch their heart rate just drop down significantly. And one of the more exciting things that happened during that exercise was, we're giving tools, and these, and part of this is how can they translate this into their own settings. And so one of our barbers said, I don't know if I would do it this way. This might be kind of complicated. He's like, and then he said, but what I can do is I can put, wet towels that I use for my clients into the refrigerator. And then when someone was feeling stressed or anxious or overwhelmed, I could put it on their face and calm them down. So we were so impressed by their thoughts of, well, how can I translate this into my own setting? So such a skilled group. We also talked with them about exercise and the benefits of that, and not only for themselves but for their clients, or even doing things like yoga. We also have talked about even using some thinking tools. For example, when they hear someone saying some pretty negative things about the world or maybe themselves, teaching them that maybe they can ask themselves a question, like, if my best friend or someone I love had this thought, what would I tell them? And that way their client can come up with, maybe with a statement that aligns more with their own values and what they might share with someone else. Like they would give great advice to someone they loved. So, but this is just a sample of some of the tools. We also have gone over quite a bit breathing exercises as well. We've had even the operators try those out and themselves. So this, this has been an incredible process. Every time we run this group, and it's myself and then, Dr. Ivy, so a psychologist that's a friend and colleague of mine. We after we meet with the group, we debrief afterwards, and we're so impressed by what has been happening. There's just this incredible comfort between the members of the group, where they are sharing, their own stories, and their own stories and challenges, perhaps with mental health, or what they've seen with their clients. I will never forget, when we first started out, from one of our champions, we heard the story of, one of their clients who called them, and all of most of the operators give out their phone numbers to their clients, which is different than a psychologist or, a physician as well. We're not necessarily giving our phone number to everyone we see. And one of their clients called them and said, I think I'm going to kill myself, which is a really scary call to receive. And, this operator then told their client, well, I don't cut dead people's hair, so come down to the shop and I'll do your hair. And when I heard that, I was blown away, because that first was such a loving, caring, kind intervention, very different, from the ER or being put in restraints, things like that. And that was also within her wheelhouse. And so I was just absolutely blown away by that, and that, and what they are doing, and what they see and how they handle the challenges that are coming up for their clients and community members that they serve. This has been a wonderful group because they're supporting each other. So, we've had operators share some pretty intimate details of loss, and they have reached out to each other. They've provided support. We've seen where our training ends, and we've seen people stay in the parking lot for 30 to 40 minutes afterwards, just continuing to talk and debrief. And, that supporting, they provide this sacred space in the community. What we're finding is that this group is becoming a sacred space for them as well. They're giving us lots of suggestions, and they're so enthusiastic. They want more of this. They want more knowledge and tools, and they want this to expand as well. And so, we had one of our operators say, can there be a summit that we do on this? And we thought, oh my gosh, there's just so much motivation here as well. And, just that, that there really is this perspective of, you are not alone, amongst themselves, but also what they share with their clients as well. And, they've given us feedback. Every operator that attends, we give them tools and handouts that they can then give to their clients. And so we're hearing from them that their clients are taking these and putting them in their, bags, or they might be able to talk about it a little bit with them. So one of the exciting things, we're thinking about some of our next steps. So one of the things I have this, not only I'm a psychologist with the University of Colorado and get to work with Terri on this great project. I also have this weird side gig where I'm the team psychologist for the Denver Nuggets. So I'm in my 4th season with them. And the NBA has really been pushing mental health, not only amongst teams, but just within the general public as well. And so they have what's called the Mind Health Program, and that's something you can check out online. And I'm colleagues with some of the developers of this program, and so we've been talking about this program, and they're really, really excited about this. And so we're looking at some ways, we've been connecting on this, and they're really interested to see how this works, and potential future partnerships on how we can work together on this. And bringing the NBA as another way of just trying to help reduce the stigma of mental health. And we've got all these amazing quotes from our operators, and things like, don't stop talking, keep going. And also this idea that, when they're talking with their clients, that, that they're planting seeds, and these seeds just continue to grow. And because they have these long-term relationships with the clients that they're serving. So they really are like, they are, they're farmers in a sense, just like planting these seeds. Yeah, Terri, I don't know if you have any other thoughts on that or just, reflections.
No, we just tried to share some of the representative quotes because they are educating us as we are educating them, and they have a lot of great things to say about the program. They really feel like this is helping them and making a difference, and that's what we wanted. So it's great to kind of hear that natural feedback. We haven't explicitly asked them, hey, is this helping or making a difference? They've offered it, and they bring in some of their fellow operators, and they're like, this is way more than I ever imagined. This is so powerful. And that means that we are making a difference. We're having an impact, and that's really what we wanted to do.
So, some of our next steps that we're looking at is expanding this. We're looking to expand this. We want to expand this into Aurora, and especially with the shops that are already a part of the CBHC's BB shop program. And, from this, barbers and stylists. I mean, the operators are talking to each other about this. And so there's a real interest in this from the barbershop and stylist community. And we're also thinking about Colorado Springs as well, where there are barbers that work with the military there and also provide a sacred space. But we're also, we're thinking about, what are we missing as well? And would certainly love any perspectives and thoughts from this group.
On the slide, it was like, 9% don't feel this way. Does that mean that 91% do feel the opposite way? Can you talk about the survey results a little more?
Well, so really, yeah. So the idea of this was like that right with this that in fact, so 91% say would disagree and say that in fact that it is a part of their job.
Okay.
Yeah.
Okay.
So 91, cool. Yeah. So another way of just putting it would just be 91% say it's a part of their job. Cool. So that's
because I know sometimes in a survey, there's a certain percentage that don't answer at all, and I was just making sure that was captured. That's really impressive. Thank you.
Yeah, and just and it is it's not a big N by any means, but we really do view this as a this is a pilot study or a pilot program as well. But that to us was really important because they really do view this as this is what they signed up for.
Right. Yeah. It seems like many of them naturally have the gift to talk to people about some of their challenges. And also with the survey, I was impressed because when Alex was first working on it, I said, this is a lot of words. It seems very long, but they had no problem with it. And it was the Likert scale, and there was, questions within the questions, but they were happy to do it. They just charged up. They know this is a pilot, but they will try to use their input to really direct where the program goes. So we were happy to complete this. And I believe they answered it truthfully, the way they really felt about it, about each question.
Is there a follow-up with the group, yes, your input is being used for this program going forward so that, their feedback is validated and they know. We in a public health stuff are always worrying about over surveying and closing the loop back with folks after being surveyed. So just curious about that too.
And I'll answer first, Alex, and then you can add in. I can honestly state that we are not waiting to the end of this to make changes. There have been some sessions where they make suggestions, in the very next session, we've made that adaptation. So they're able to see that.
That's awesome.
Yeah, the survey is going to be a more formal way to show some changes, but definitely we can give quite a few examples of how we did things a certain way at the very beginning. We got feedback from them, and the very next one, and they see the difference, but we also call it out. We heard you, we listened to you. Here's, the next rendition of it. So that's worked out pretty well. And Alex, I don't know if you want to add to that.
Sure. Yes. Yeah. I mean, yeah. So we will be giving out, a follow-up at the end, to do essentially a pre-post with the same questions. And the other thing though, we are going to be doing some individual interviews with folks. So we've got a researcher that's going to help us out with essentially doing some qualitative research with this as well. So that way we can really get some of the stories. I mean, we have some, but I mean, we've heard some incredible stories from this as well. And I mean, the fun thing, I mean, and what I'm so pleased about is we really, as Terri had mentioned, we have changed this based on what the operators tell us. So for example, when we went into the topic of depression and suicide, because of the weight of that and the, what we learned from them, the discussions, the stories, we made that into a two-part training, because we wanted to provide the space for them to talk about all of the losses and what they've seen within, for themselves and within the community. And then we pushed really to provide the tools to the next one as well, to make that space for them, because just, we know in the Black community, the suicide rates have gone up significantly, especially during and, post-COVID as well.
Yeah, and I wanted to just add too that even though we have these surveys and we're doing things that may be viewed as research, I mean, that's not the way we articulate it with them. This really isn't a research project. This is a real life project, but we're just trying to capture the information in a more quantitative and more formal way. But by no means are we experimenting or doing research on these operators. I mean, we really are providing a service, but we want to ensure that what we're providing is what they need. And we also want to be able to share with other people. So that's why we have this formality of surveys and standardized interviews, so that we can actually educate others as well as ourselves. But it's very important to us that people don't feel like there are research subjects or anything like that. I always like to kind of make that clear, because we may use the terms research and surveys, and someone looking in from the outside may say, oh yeah, this is a great study they've got going on. No, this is practical application of information that we discuss with them. So, but we will have some hardcore metrics that are going to support that, and everyone can learn from that and we can share.
Yeah, any other questions? Or I know there was one that Julia, you asked. I think Terri answered it in the chat about Black birthing health.
Yes, and it just did I answer your question? Because CBHC is starting to do a little bit, and people are starting to reach out to CBHC, Colorado Black Health Collaborative, on that particular issue. And I know I participated in a session on the movie Aftershock, and people have been reaching out to us since that time. And we do have our executive directors very interested in women's health and perinatal mental health and the birthing issue. So that's something that is underdeveloped right now with Colorado Black Health Collaborative, but definitely on our radar, and we're starting to do some work. And our executive is definitely hopeful that she can have that as a featured program that we're going to work on at CBHC.
Well, we just wanted to, to share our appreciation. First, this really, this whole project came out of, first Terri and I getting a grant through the Colorado Center for Translational Sciences, the Institute, so with the University of Colorado. And that was focused just on developing our relationship. We then, then through our work together, we were able to get the Caring for Denver program, to fund this pilot program and to help begin this. And, it has blown us away in terms of what we've learned and, the impact that these operators have on the community they serve. And then, we're so thankful and appreciative to our stylists and barbers. I mean, they have, they want to help, and their desire to do so is palpable. And so it really inspiring. So Terri, I don't know if you have any additional appreciations, or I appreciate you. Yeah.
I appreciate everyone involved with the program, the stylists, barbers, our team. Everybody has put their heart and soul into it, and it's great. And we're just hoping that we can continue to be in this space and share with others. So we appreciate the opportunity to be here today to let you guys know a little bit about it. We did the Cliff Note version. There's definitely more, but we didn't want to dominate the entire session. But if you ever have any more questions or want us to present a little bit more detail, feel free to call us back.
Thank you so much. That was really informative and a great innovative program that I'm excited to learn more about.
Yes. Courtney, Tassin.
I'm on my phone. I'm having like the worst luck with Zoom this week. So during the presentation itself, I'll probably have to turn my camera off so that my phone can actually pick up the audio. So, well, with that, I will go ahead and jump in if that's all right. Hi, everyone. My name is Courtney Tassin. I am the Crisis Intervention Program Manager for all of the City of Aurora, which means I just oversee all of our crisis programs here, to include our co-responder team and our civilian-led mobile response team, which I will be talking about today. Just a little background on me. I actually started on the co-responder team as an intern many years ago and have served in kind of all of the roles on that, to include being a clinician and now oversee all the programs. So I have the firsthand experience of being out on the road, responding to these calls and seeing what the community sees every day, as well as now from the administrative side. So if you could go to the next slide, please. Wonderful. So I just wanted to start off. I think it's important to know what it is we're actually talking about. So this is just kind of the rundown of our Aurora Mobile Response Team, or AMRT, as you might hear it. So what even is it? AMRT is a team that pairs a paramedic or an EMT. We've started utilizing EMTs as well, from Falk Rocky Mountain with a licensed mental health professional. I realize now that this says Aurora Mental Health Center. The new program partner is UC Health. We recently made that switch in January of this year, and I apologize I didn't catch that earlier. The team currently operates Wednesday through Saturday, 8 to 6. We are currently trying to hire for a second clinician to service the other half of the week. We'll talk a little bit about the data-driven pieces to why our operation hours are what they are. We initially started actually 10 a.m. to 8 p.m. and we found that there was actually more need in the morning, which was very interesting. I too am not a morning person, so I imagine that maybe that's part of it. We are currently operating mostly in West Aurora, so anything to the west of 225. That really hits our Colfax area, services some of our unhoused folks in the area, as well as just some of our underserved populations, to include minority groups, things like that. So we do venture outside of that West Aurora area on special occasions, and that's usually at the request of the police department. This team is not to necessarily replace PD, but to give them another tool in the emergency services toolbox. So there are plenty of calls for service that come into 911 or the non-emergency line that are low intensity, and the primary concern is mental health or just need for a resource or some sort of connection. So this team is unarmed, so they don't fulfill any duties that law enforcement might, and they're only responding to calls that haven't mentioned weapons or there's no component of active violence towards self, others, or property. The team themselves will kind of talk more about statistics later, but they are typically the primary and sole response. If they're not, that means police were there first. Police say, hey, this feels really out of my scope and like I don't need to be here. I'm going to call AMRT and ask them to come take over. That happened 108 times just within our first year of being on this road. So that was a really huge success for us. The team can be contacted through 911 or the non-emergency line. We don't have a backline at this time. Currently, in order for safety purposes as well as just general efficiency, everything goes through City of Aurora's public safety communications. So what happens is the team, when a call comes through to dispatch, caller will give all of the information there and put it into call notes. Whenever that call is created within the system, our mobile response team can open the computer, literally click on the call, read everything that that caller provided to dispatch and say, hey, that sounds really appropriate for us. We'll take it. All of the police department, all of the fire department is able to see AMRT is taking that call. We know they've got it and it's good to go. So that is kind of how that works. Typically, this team will start with a phone call first, just because not many people call into 911 expecting the team. So we like to make sure people are okay with that response, because sometimes people really do want the police or really do want the fire department. So we want to make sure that while we want to provide the best service, we're providing the service people actually want. We like to provide, here's the background of what we do, here's how we can help. Your call came on our radar because it seems something really appropriate for us. Can we come help you today? And typically people say, absolutely, I had no clue you existed, that's awesome. And then there are some people that say, I would really like an officer, which in that case, AMRT can request an officer to go with them. And so once the person is on scene or the team is on scene, if the officer comes with them, they can manage whatever part is needed by the client from the officer. And then the officer can go back in service. He can continue providing any support resources that might be needed. Next slide, please. This is just some historical information, not nearly as exciting as the rest of the stuff we'll talk about, but just to kind of give you a perspective on how the team came about. Planning for this team actually started in about 2019. There were conversations very early on, and around November of 2020 is when City Council actually approved the allocation of funds. They wanted to create something similar to the Cahoots program or the Denver Star program, both of those utilizing a medical model of response for mental health calls for service. Around December, we initially started with some agreements for community partners. Again, we used to work with Aurora Mental Health, that is now UC Health, and that changed as of January of this year. These programs created kind of a MOU, a pact almost, to start up this pilot program. Initially, the pilot was approved for 6 months, and at the end of the 6 months, we would evaluate if it was something the community saw as beneficial, the public safety partners saw as beneficial. Surprise, it was. We all really liked it. And so we did get to keep operating, which was wonderful. The real implementation and planning period began around August of 2021. And through that time, we had a lot of trainings for the staff who were hired, to include trainings on situational awareness, the actual motor doctor computers or MDCs that the police use, as well as police radios. And we'll talk about that a little more in the next slide. August 25th is actually when they had kind of a soft launch, which let them just get used to the city geography, understand the technology, and what it actually looks like to be a first responder. Many clinicians are very vital to crisis work, but it's very different to be in someone's home providing crisis care or responding to a 911 call than it might be in an inpatient or some sort of walk-in facility. So it's kind of a bit of a learning curve in the very beginning, and we wanted to make sure that we allowed them that time prior to fully launching when we did on September 8th, so that they had kind of an understanding of what the role looked like and we can work out any kinks that might have come up. Next slide, please. So whenever we first started, we identified a few different areas of training that were not only around cultural competency, but safety and as overall, software and things like that. We really prioritized a lot of that cultural competency piece. So we looked at LGBTQ plus affirming care and best practices, which was actually provided by UC Anschutz. We had human trafficking awareness and considerations provided by the Laboratory to Combat Human Trafficking. That one was huge for us because one of the biggest things I saw on the road as a clinician myself was human trafficking. So that was something that we felt was very important to make sure that our teams were very well aware of. We also put them through the mental health first aid for first responders. Obviously, our clinicians came in with this knowledge, so it was important for us to send our public safety partners through that with this one. And then harm reduction as well. So while we want everyone to be happy and healthy, we understand that sometimes substance use is just a part of someone's coping. And we have to be able to meet people where they're at to either help resolve that crisis at the time or set them up for success in the future. So partnering with HRAC or the Harm Reduction Action Center and Lisa Rabelais was really important for us when creating this program. The additional things you'll see here are scene safety and situational awareness. To make it very blunt, some of the main feedback we get about these programs in the world is everything's great until the social worker gets shot. And while I can understand the sentiment behind that comment, it's not very helpful as a comment in itself, but we do take safety very seriously. We set these teams up for success, and we'll talk about safety considerations in the next part, because if we don't feel safe and we're not communicating from a place of safety, we can't create safety in the person we're trying to help either. And so much of crisis resolution is creating safety in that person's life in that moment and some stability. And then again, you'll see dispatch operations in the motor dock computer, just kind of vital to the actual operations in itself to make sure that whenever we're actually providing the service, we're doing it well and we're doing it in an efficient way. Next slide, please. So this is a lot of information all on one slide. I can absolutely attest to that, but safety is one of our primary goals, not just for the people we're serving in the community, but also for our staff. We have various levels of safety that we have implemented, both through trainings and protocols. You'll see that in our standard operating procedures, we worked with every public safety partner within the city of Aurora to help create best practices and create an SOP that allowed for every situation. It provided guidance to the team so that pretty much anything they ran into, they would have an understanding of how to handle that. We also made sure that we had a very strict criteria, especially in the beginning, of the kinds of calls we were going on. We're not going to send an unarmed unit to a call with a gun or a domestic violence call that is inactive violence. Could these teams be requested maybe after the scene has been neutralized and safe? Of course, and that does happen often. But in the very initial stages, we wanted to make sure our scope was a little smaller at first. That way we didn't bite off more than we could chew. We also utilize bulletproof vests. They are provided to all staff, police radios, and motor dock technology. This creates an open channel of communication, not only with dispatch, but with fire and police, to ensure that if there are safety concerns that come about, they're able to directly contact them if needed. I'm proud to say the team has never had to request emergent backup on a call ever in the entire almost 2 years of the program being in operation. Very proud of that. Now they have had to request PD to come because maybe someone wanted to file a police report. So I'm not going to say police have never come on these calls, but when they have, it has not been for safety concerns. You saw on our last slide, we had a lot of information or a lot of trainings on safety. We also looked at how are we triaging calls and how do we determine if they're appropriate. We also trained the team on when it is appropriate to ask for police cover. If it's something that seems like it might be appropriate for the team because it's mental health in nature, but perhaps there's a safety concern, the team can request that PD initially go with them. And then while the PD is standing by, they can determine, okay, I feel safe, PD, you can go back in service. And PD might not have even had to engage with that client at all. So we encourage the use of safety measures like that. I will say it's rare that that happens because we have trained them on how to triage calls appropriately. Our team also provided training to dispatch, the police, fire, and citizens themselves on the function and limitations of AMRT. It's very important we stay in our lane and we use our other public safety partners like our crisis response team, which pairs clinicians with law enforcement to provide a spectrum of care, because we want to make sure that if we're not stepping out of our role, if we're stepping out of our role too much, then perhaps we can invite safety concerns in. And with programs like this, you really can't risk that because that's how you end up getting the feedback that these programs are unsafe. We wanted to make sure that we had very collaborative relationships with our public safety partners. So we attended briefings, we visited fire stations to make sure that they could ask any questions that they might have about AMRT and so that we could get feedback. We wanted to understand what the needs were of the police departments, the fire departments, and EMS so that we could really provide not only the best quality of care to the citizens, but to do that in partnership with our other public safety partners. We provided the AMRT procedures via email to all of those departments as well, which was really helpful. And when these teams did have to interact with each other, with PD, with fire, with EMS, we wanted to make sure that there was communication on those scenes of introducing, hi, I'm from AMRT. Here's what we do. Here's how we can help you. And that alone actually increased the number of requests from other public safety partners. I also do regular quality assurance checks. So I will go in, I have a software that lets me see every single call for service that AMRT went on. And I'm able to pull it up and say, okay, that seemed like it was a really appropriate, safe way of going about that. We also have weekly team meetings where we can talk through calls for service to ensure that they feel like they're being utilized appropriately, not only by dispatch, but by PD, citizens, et cetera, to help us determine if more trainings need to happen for those public safety partners. And we also regularly review the calls that are kind of coded for an appropriate AMRT response. Now that we are almost 2 years into this program, we really don't struggle with that because, again, the team takes the accountability and the kind of point on determining which calls feel most appropriate for them. Next slide, please. So data collection and program evaluation is something that's really important anytime you have a program, but especially when you're trying to prove that it's helpful and that it works. So these are just a few of the metrics that we collect. The main goal for these kinds of programs is to A, not need police on calls just in general, but also to divert people away from jail and the emergency departments. So this is something that is kind of the core goal of any co-responder or alternative response teams. We want to make sure that people get the help that they need in the lowest level of care possible, and that's appropriate. So when we can, we try and resolve the calls on scene, either through safety planning with the individual, helping them with means restrictions. So if they're talking about wanting to take all of their pills, how do we navigate that to make sure that the person doesn't have access in that quantity or has some other safety parameters put around that way that perhaps that person is more safe at home. We also like to utilize the walk-in crisis center with Aurora Mental Health. That's been a really great community partner. And that's another alternative to emergency rooms. So say someone's not necessarily safe in their home, but we have this lower level of care where they can speak with a therapist and they can get some additional safety planning and resources. That's something we utilize a lot. We're looking at if many of our clients are unhoused, which we find that less than 5% of the clients that we serve have been unhoused. For whatever reason that is, I'm not entirely sure just yet. We've been digging into that. It seems like a lot of the reasoning for that is because our outreach teams in the area are doing a really great job. We're also wanting to understand how often is police recognizing that AMRT is a more appropriate response. So how many times is PD requesting AMRT to come take over their scene? Like I said, within the first year of the program, that happened 108 times. We're now at about 225 times in the 2-year span. So very exciting to see police recognizing their role and recognizing the limitations and also utilizing a program like this. So whenever PD requests the team, the goal is to put them back into service. Sometimes police do need to stay on scene because maybe it's an active criminal investigation or things such as that. But AMRT is there to provide the support that might be needed or connection to resources that might be needed. But most of the time they are able to relieve the police department from the scene and PD is able to go back in service. And we also are looking at the demographics and the location of the call, as well as the time that the call comes in. So like I'd mentioned in the very beginning, currently our hours are 8 to 6. They used to be 10 to 8. And we were seeing that we were getting a higher volume of calls in the morning time. And we tracked that by looking at all of the calls for service that came in through City of Aurora 911 and said, okay, these are the ones that would have been appropriate for the AMRT. And we ran an analysis and again, it gave us a heat map that showed our prime hours from about 7:30 a.m. to about 6 p.m. every night. And next slide, please. So these are just some current statistics. You'll notice it only goes to December 2022 right now. It's because we're working on a finalized report to get us our cost reallocations and things such as that. So that is why that full number is not just there yet. But from September of 2021 to December of 2022, they had 503 calls for service, which is a lot when you're just one tiny team. Again, it's one clinician and one EMT right now. It's really difficult to hit a ton of calls when it's just one of you. For context, our crisis response team has 5 officers, 5 clinicians, and they went on about 1,200 calls last year. So still very comparable to what we're seeing. The team was actually able to divert 46 individuals away from emergency rooms by utilizing lower levels of care, which showed about a cost reallocation or cost savings of $143,000. So really big performance indicator for us. And we were actually able to help mitigate or divert from jail 4 times, which pretty impressive, honestly, with a team like this, because often we're not going on calls that might rise to criminal nature. So a lot of these look like diversion from trespass charges or diversion from a shoplift charge, something that might be petty and small and maybe more related to mental health than true criminal intent. So we work really well with the police department on that, and they often will give us that leeway to advocate for things like this. That way we're truly getting the person the help they need or the type of assistance that might be more appropriate. You'll see just a breakdown here of the main kinds of calls types. So anytime a call for service gets called into 911, they will code it as a call type. So welfare checks are kind of a catch-all. Could be a man down in a field. Maybe it's someone taking a nap and a passerby said, hey, that looks, concerning. Can you check it out? All the way up to maybe someone who expressed suicidal ideation and someone just wants a little check-in on them. We also have a suicidal party call. So if someone calls in directly stating that they're having suicidal ideations, maybe they have a plan, maybe they don't. That's the second most utilized call type for us. And then an unwanted person. So what this means is maybe it's someone who a business owner doesn't want on their property, but they're not quite willing to trespass them. AMRT has been able to show up, say, hey man, I can give you a ride somewhere else. Let's go. That way you don't get in trouble. And 9 times out of 10, that person says, that sounds great. Here's where you can bring me. And it's usually within city limits. We have traveled to Denver to bring them to a shelter of some kind or a resource that might not be available in Aurora, because unfortunately we only have one shelter system here. And then fire assist is also kind of a catch-all term. Sometimes it can be an accident. It could be someone who actively attempted suicide and is now kind of the primary concern is medical. AMRT has been able to assist fire often, which has really helped our partnership there. And then you'll see the other column that kind of just spans all over the place. And you'll notice that if you try and add all of these up, it will not add up to a total thing. And that's because it's a lot of like one calls that, we're in a different category. So if you're really interested in knowing exactly what they've been on, feel free to reach out, but it's not nearly that exciting. And if we can go to the next slide, please. So I talked about how we kind of collected our data to determine what hours of day, what days of the week they were coming in. So City of Aurora Dispatch actually created a call code or something that they put into the call notes where they put hashtag AMRT. And when I looked at hashtag AMRT in the system, I could identify it through a search and it'll spit out every single call for service that dispatch identified. So you'll see here that every single area of the city at every time during the day had a call that was identified as appropriate. Now, you'll see that as of 5/23 of this year, 1,173 calls for service were identified. It's likely that this number is much, much higher because it relies on the dispatcher remembering to put it in. While our dispatchers are amazing, there's a lot of things they have to think about and really focus on, and remembering to put in that call note's not necessarily the forefront of their mind. We really use this in the very beginning of the program so that we can adjust our operations times. And we still do have dispatchers that will put it in, but it's kind of dropped off now that the program has been fully sustained. But yes, you will see that there is a call for service at every inch of this city, and there's a lot of them. Next slide, please. I just wanted to provide some examples of calls that might be appropriate for the mobile response team. So you'll notice in this very first section here, this first paragraph, the person is expressing suicidal ideation, but they're not really naming a plan. They haven't taken any action to hurt themselves. They're just feeling overwhelmed and feeling like maybe they're moving towards the side of not being able to keep themselves safe. And what I mean by not keeping themselves safe is that they feel like if they remain alone, they remain in their current situation, that they might take steps to actively harm themselves. The reason that this call is appropriate is because there's no weapons, there's no active violence towards self, others, or property, and the person is actively wanting to speak with someone and would probably benefit from a therapist and an EMT as opposed to an officer at the time. The second one here is an individual who is maybe on a business or a property of some kind. They're talking to themselves. When staff go to talk to them, they don't really know who they are. They don't know their name, where they're at, and they're struggling to kind of be coherent. Staff is worried for them. The person's not violent. They haven't tried to harm anyone. They can just tell that maybe there's some additional support needed in that moment. We get calls like this all the time. A lot of times our team is able to assess and determine if a higher level of care is needed or if there's some additional resources that might be needed as well. Next slide, please. Next, I wanted to talk about inappropriate calls for service. So this first one here, an individual tells dispatch that they're feeling suicidal, that they have a gun and they plan to go into their tent and shoot themselves. This obviously would not be appropriate for this team here because there is an active weapon in play and a plan to use that weapon. Doesn't mean that our teams can't call the person and try and de-escalate. That does happen often, but this is also why we have our crisis response team that is the next step up in intensity. So all of our teams operate in a spectrum of care. So for this call, just because the person does mention a weapon doesn't mean that they won't get a mental health-based response. We want to make sure in the city of Aurora, we have multiple programs that provide multiple responses so we can provide the right response at the right time. This second paragraph here, you'll see it's a similar situation to the individual in that last slide, but now this person pulls out a knife and threatens staff saying, "I know you're all trying to kill me." While everyone, or not everyone who is psychotic or has symptoms of psychosis is violent, in fact, they're more likely to be victims of crimes, there are situations in which someone might be violent. And when that happens, this team is not necessarily the most appropriate. But again, we have our crisis response team who could step in, take this call, and still provide a trauma-informed approach, or more trauma-informed than a normal police response. Next slide, please. This is a very small flow chart, and I apologize, it's very tiny on the screen, but this just shows a little bit of a flow chart of how all of our crisis programs work together. So you'll see that kind of main criteria of questioning, that line of questioning to determine, is this a call that's appropriate for AMRT? Are there weapons? Are there active threats of violence? If there are, then is CRT available, our crisis response team? If not, is a CIT officer available? We have 3 different main options here. Those are kind of the spectrum. And then does it fall within AMRT's area of coverage? If not, is CRT available? If CRT is not available, is our crisis intervention team available? And so this is kind of how we operate as far as who goes to what. Next slide, please. Some of the keys to success that we have observed within this 2 years of operating AMRT. The most important thing was having a strong relationship with PD, fire, dispatch, and our EMS partners. Without this, we could not do our job. If we are isolating to our public safety partners, our ability to work alongside them is now very fractured. So one of the main things that was important for me coming onto this program was to ensure we had open lines of communication, frequent interaction as far as outside of calls, and the ability to take feedback from all of these public safety partners, as well as provide feedback to them. So that that has been paramount to some of our success. It's actually really cute. PD loves AMRT. They request them all the time. They ask for them all the time. They ask me when they're getting more of them. And if AMRT is on a call, they sometimes will just pass by and wave, and they're like, "Oh, we love you guys. Thank you for taking that call." So that partnership has been really great. Having access and utilization of the police computers and radios, providing that direct communication, that line of communication, has been so helpful. So programs such as STAR, whenever we were observing, did not have that. And whenever I came from the crisis response team to making this program, we identified it as a way of helping keep this team even more safe. Because if we can see the call notes, we can get the full picture, as well as getting the contact information for the person calling in, or even maybe the client who is going to be the subject of this call. It has allowed us to operate and expand our capacity while also staying safe. The next piece was community outreach. We did a lot of community outreach in the beginning, both to public safety partners, but also to the different groups that we might be serving. We made very intentional efforts to talk to shop owners within the Colfax area, as well as other areas that might be high, call volumes within the city. We wanted to make sure that they knew that this program was available and how to request us, how to reach us, and what to expect from one of our responses. We also did this with different groups, cultural groups, as far as, you know, the LGBTQIA plus community, different cultural groups such as the Asian Pacific Islander, the Black community, pretty much anyone you can think of. We made a very intentional effort to talk with them and make sure they understood how we worked. We also looked a lot at the frequent updates on statistics and cost reallocation. This is one of our main performance indicators. We are providing these services in a way that meet the needs of the community and also are fiscally helpful. And then our data-driven operations. So by looking at those statistics frequently, we want to be able to adapt our operations to make sure that it fits that. And we're also keeping up with leading practices and taking information from other teams across the nation, research articles, things like that, and then adapting our response to be appropriate and fit with that. Next slide. So lessons learned. I don't know that the slide changed. There it goes. Thanks. Actually, whenever we first started the program, we had kind of a base SOP. I learned very quickly that you have to have a very detailed SOP or standard operating procedure that gives your staff the protection for if they have to act in a certain way. So something that we initially did not include in our SOP was how can we disengage with someone who maybe is becoming violent while we were on scene? What is our protocol if someone begins escalating to the point that they are no longer safe to interact with? We created pretty much a protocol around any possible situation. Someone begins having a medical emergency that falls outside the scope of the EMTs or the paramedics. Someone wants to file a police report. Someone is now escalating, becoming dangerous to interact with. We have a protocol and some sort of policy that dictates what is appropriate and what is not appropriate for these teams to do. We also created kind of a roles and responsibilities checklist for each of the professionals involved to make sure that they're staying within their scope and not acting outside of that and perhaps increasing the liability and the danger to the community. Training public safety partners, including dispatch, initially that was something that was overlooked. And so very quickly, actually before the final launch, we realized how important it was to make sure that police, fire, EMS, and dispatch truly understood the mission of the program, as well as how to appropriately utilize them when it's not appropriate and what to expect when we got there. Initially, dispatch wanted to directly dispatch the team, so they would look at a call and say a lot of other responsibilities and things going on that sometimes things can get missed. Very early on, dispatch had directly dispatched them to a call with a knife. Thankfully, another officer saw and said, hey, there's a knife on that scene. I don't know that AMRT should go to that alone. Thankfully, that was caught and the team was able to go together with a police officer. And then the police officer was actually able to go back in service and it became a non-issue. But us being able to self-dispatch, look at the calls and identify and say, that looks like it's appropriate for us, we will go. It takes pressure off of dispatch, who is handling 500 million different emergency situations and having to de-escalate on the phone themselves. And it also ensures that we're going on things we truly feel like we have the capacity to help with. Training our staff was the next thing. I wanted to make sure that the staff understood triaging, and I don't think we paid attention to it enough in the very beginning. So right before we launched, we started doing a lot of practice runs. So printing out calls for service that came in the days before, the weeks before, and saying, okay, what does this call note look like? What would you want to know more from? What would your plan of action be? So training the staff to make sure that they truly felt safe going out in the field, that they were going to respond safely themselves, and that they were not going to do harm when they did go in the field. And then the very last one here, and I kind of mentioned it earlier, starting with a phone call prior to traveling. So that became a big protocol for us later on in the process, because there were many calls we went on where the person says, what the heck, why are you here? I wanted police. And we're like, oh man, yeah, we probably should have asked you. It's not very person-centered to just show up and assume. So us starting with a phone call also helps us to allows for us to begin that de-escalation process sooner. And that way, when we do get on scene, it's maybe more effective and more efficient. and we're able to connect that person to whatever is needed in the moment. Next slide, please. Some of the feedback we received, just have to toot our own horn here. We actually get a lot of great feedback from our public safety partners. This one here, I won't fully read it, but you can see it for yourself. One of the police District 1 sergeants actually sent me this email, was so grateful for the service that AMRT was able to provide. At the very end, he says, I've been in law enforcement for 29 years and I fully support this program. So that was such a great thing to hear, and something for me that said, we're doing the work. Like, we are successful. This is awesome. While of course, you know, the community is also the very important feedback to get, to hear from our public safety partners who, to be completely honest with you, I was worried would not support these programs, actually support them, tells me that we're on the right track. And speaking of community feedback, if we can go to the next slide. We had a mother of one of our clients reach out to me. This was probably a few months ago, actually. We had a second interaction with her daughter, but she was one of their very first clients that we ever had. And AMRT had been working with this individual. She'd even told, this was actually one where PD had gone out first and requested AMRT, saying, I think this is more in your scope and your lane. PD ends up leaving. Prior to PD leaving, the daughter here was very much stating that she was going to fight. She didn't want to get on the ambulance. She was not going to go. AMRT took 30 minutes, was able to sit down with her, talk her through it, understand maybe the trauma that was coming up with having to go to the hospital, kind of decrease some of the anxiety around that, and actually truly go with her in a very person-centered, trauma-informed approach, go with her to the hospital and help alleviate some of the stress there. So we get emails like this probably weekly from clients in the community. I just had one recently for AMRT where a young man was struggling with substance use, and AMRT went above and beyond to get him connected to services and resources and got him into detox and connected him to the Ready to Work program. And he's now been sober since that encounter and is, you know, set up on his way and working down a really great path. So really great to see the feedback in the community. And then next slide. This is just the media coverage, again, just tooting our own horn here. We've gotten a lot of great coverage from the media to talk about the program itself, how it's utilized. Again, this kind of went back to our community outreach approach and why it was so important in that way. So with that, next slide is just my contact information. I so appreciate the time to talk with you all about the program.
All right. Well, thank you all so much for joining. Courtney, thank you. Apologies for the challenges, but glad you could make it. A lot of great information. And thank you to Drs. Reed and Richardson with Project HairCare. Thank you all so much,